Welcome to CeGaT, the best possible exome diagnostic.
Hello, and welcome to our webinar on exome diagnostics. My name is Stefan Griesbach, and I will be happy to present in the first part of this talk our exome diagnostic lineup, while Martin Ritterle, here my colleague, will present in the second part of the talk clinical cases. Let's start. So we as a company, CeGaT, focusing on sequencing services, both in genetics diagnostics as well as in research and pharma solutions, raw data delivery, clinical research cases. First of all, let me give you a very brief background on us. So first, our mission is to utilize next generation sequencing for all scientists and bring these diagnostic knowledge to sequencing services and also to clinical applications. So what you see here on the picture is Dirk and Saskia Biskup. Saskia Biskup is our medical director. She is a medical professional, a medical doctor specialized in human genetics, and we founded together with her husband the company 12 years ago. Which brings me to this, and don't worry, I will be going very briefly above this slide. So, as I just mentioned, we have been founded back in 2009 and immediately worked on our accreditation handbook. So, our company is accredited according to ISO 15189 and CAP and CLIA. So, this is something actually, interestingly, not yet mandatory in Germany for genetic diagnostics. Still, we are strong believers in utilizing accreditations. We are strong believers in highest quality. The only thing actually I want to point out here is, because we will focus on this today, that back in 2019 we actually introduced the CeGaT EXOMEXTRA, and the huge majority of this talk will now be subsequently on what makes this EXOMEXTRA. So this is us. Actually, this was us prior to Corona times. This is our 10-year anniversary photo. We have been slightly growing since then. So right now we have more than 300 employees. Actually, we're closing in on 400 now as we're speaking. And we're utilizing the most recent technologies. We're constantly looking on the market, what is available, what will bring us to the next level, and what can be used best to offer the highest quality sequencing services, to offer the highest quality genetic diagnostics. As I mentioned before, we have two business areas. The one is genetic diagnostics, and again, you see Saskia here, and we will speak about that now a little bit more in depth. On the other hand, and I still want to mention this, even so it's not part of this talk, is our research and pharma solutions. This is a service where we offer research services, raw data delivery services on exomes, on genomes, on transcriptomes, all different kind of research applications that can be addressed utilizing next generation sequencing on the level we are talking about here. Okay, let's speak about genetic diagnostics. And you see with the subtitle here, extra insightful results. That's like the key prime message we want to give across. We will provide in our diagnostic services results that are extra insightful, that can be used in clinical settings best. When we start, and just take one small step back, when we utilize NGS in genetic diagnostics, what do we actually need to do? So first of all, why we are doing this? We're doing this because a single genetic variant can cause a serious disease. Something that when we have started the company was not that well established. Now, 12 years later, actually it is quite well established. And you see that when you look around, there are already nowadays quite a substantial amount of genetic diagnostic services. And on the other hand, and this is we will not speak about this today, still it is very important, we can determine the effectiveness of cancer treatment options utilizing NGS-based diagnostics, as tumors are more or less to be considered a genetic disease. So when you look on genetic diagnostics, you virtually have three steps to take. The first one is the laboratory work. So you have the sample intake, you isolate the DNA, and then you need to sequence. And it's quite important what you're sequencing and how you're sequencing, because the quality of the sequencing determines the later results. It's the fundamental base level on everything we do subsequently. So sequencing of the relevant genes, sequencing of a little bit more than only what is necessary. Sequencing this on a high quality, very unique, very reproducible, is the basis for reliable genetic diagnostics. In the second step, what we do is we have a bioinformatic analysis. So we have now laid the basis in our laboratory, but we still need to look into this more into detail and say, well, all these variants that are identified cannot be evaluated by a human in a reasonable amount of time if we don't supply it to bioinformatics. So it starts actually with aligning the reads to the reference genome, to calling variants, to sorting variants. So all of this, what is needed in order to have a streamlined process that allows short turnaround times, but on the other hand, don't lose anything to be heard. If you are too stringent, you lose things that you wanted to interpret. And similarly, as we can only reuse in bioinformatics what has been sequenced, we can only interpret in the subsequent step what bioinformatics leaves our diagnosticians on the table. And the last step actually is the medical interpretation. In the medical interpretation, the individual variants are looked upon, sorted, evaluated, classified, and then decided which of these are actually responsible for the described patient's phenotype so that they can be reported or should be reported in the medical report, and to give back the treating oncologist, the treating physician, what is needed to best care about the patient. So fundamentally, the goal of this whole process is to identify the genetic cause of disease. So let's speak a little bit, or start speaking about exome diagnostic in particular. So first of all, what is the exome? So the exome is defined as the sum of all protein encoding parts of the genome. The genome has approximately 3.3 billion bases, and the exome is, depending a little bit how you count, something like 35 to 40 megabases. So this corresponds roughly to a good percent, 1.5% of the genome. So it's much smaller what a genome would offer, and more focused. Still, we find that 89% of all disease-causing variants are located within this exonic regions. But what's about the rest? What's about the 11%? So first of all, there are the intronic variants. Intronic variants are variants, or intergenic variants. These are variants that are not located in the exonic region, but still are variants, and in this particular case being disease-relevant variants. Of course, there are many, many variants intronically that do not cause any kind of disease, at least to our knowledge today. But there are a particular number, 28,000 roughly, that cause a disease. And this is something, when you do a good exome diagnostics, you should not neglect, but rather encourage. So you should do these as well as part of your analysis. And I mentioned already before that we have thousands of genetic variants, but to give you rough numbers, what we're looking into is something like in the range of maybe 50,000 variants that make the difference between different humans on this planet. The majority of them cause not a disease, otherwise we would all be having a disease. But of course, everybody of us shares variant of high risk. Everybody of us has variants that are simply responsible for us being a little bit more tall, a little bit less tall, different eye colors, and so on. So this exome diagnostics, again, focusing on genetic diseases, what we're looking into here, is one of the most powerful tools in general. And targeting the exome means we're targeting about 23,000 genes, which is quite a lot more than actually is directly associated with diseases. Why are we doing all of that? So I spoke already a little bit about, yes, we have cases we want to identify genetic causes of disease. I want to give you one background before I start into the specifics. And this is a girl we had. The age was about 6 months when it came to us, and it was identified with a bone marrow developmental defect. The brother died with very similar symptoms at the age of 7. So it was very obvious that there should be some genetic reason for that disease, even so the physicians had not really a chance to see any reason for that. And so the only course of action that they currently could do is to schedule this girl for a bone marrow transplantation. Survival chances are not really good in that age, And so they approached us in parallel while scheduling that and said, can you please look if you find something? And again, this is a short video about her status when the samples got to us. And what we did here is a trio exome diagnostics. So we sequenced both parents and the kid, and I will come to more details on that a little bit later in the talk. And what we found is that there's a variant, a defect in the TCN2 gene, which encodes for vitamin B12 carrier protein. So what happened is that this girl, even though the blood values of vitamin B12 have been absolutely normal, the vitamin B12 could not translocate into the bone marrow. And very openly, we got quite lucky, because not only have we found this variant, but we also found a publication, a very recent publication, where a patient with the similar symptoms and a similar genotype was identified, and then the pediatricians treated that patient with high dosage of vitamin B12 in order to compensate for the reduced translocation into the bone marrow. The physicians here in Tübingen did the same, and this is the girl about 1.5 years later, so at the age of 2. She develops absolutely normal, and the only thing she needs is vitamin B12 in high dosage. So this is quite dramatic cause of action, and obviously not all of the cases we have are that dramatic, but still it showcases the importance of genetic diagnostics, the importance it can have at least. Okay, so I showed you that picture before, a little bit differently, but still we have these 3 steps. And as I mentioned, we are a company that tries to get the most out of each case, that tries to do the best job. So we looked on each of these steps and said, okay, how can we improve? What can we do better than what is currently available? And the first part is the laboratory part, the fundamental basis. So what we have here is, we have something that we, from a marketing perspective, call the extra smart clinical design, but it actually holds pretty much true. Because what we did is, first of all, we started with the coding sequences. Of course, it's an exome, but we're not utilizing only the coding regions that are most of the times considered be the standard exome. No, we expand quite a lot, quite substantially about that, because we have 12 years of experience in designing individual categorized gene panels. So gene panels are curated list of genes, and before the exome was at the level that we're looking now today, we sequenced individual enrichment panels for these genes. And when we designed these gene panels, we looked a lot into the literature for individual transcript or cryptic exons and so on. So we have a lot of knowledge in what actually could be part of the coding region, and we utilized this optimized coding region definition in the design of the exome. So we added a substantial amount of targets that are in the off-the-shelf exome not present. The second one is that we take the mitochondrial genome. Mitochondrial genome is quite important, especially for metabolic diseases. Of course, there are diseases where it's not that important, but still, if we have the mitochondrial genome, we can look into that and we can identify, especially with mitochondrial related diseases, metabolic diseases, we can identify these ones. So it should be an integral part of every serious exome diagnostics. Then I already mentioned that there's about 28,500 intronic variants from HGMD and ClinVar. So these 28,500 variants we obviously included into our enrichment as well, so that we cover everything that is there. And then finally, we sequence all of that with over 100x uniform coverage. And this is quite important because today we're speaking more and more about whole genome sequencing for clinical genetic diagnostics. And this sounds, of course, quite fancy, because what can be there more than the genome? But then on the other hand, when you look onto this a little bit more closely, what we see is that we solve at least a few % of the cases with mosaicism. And these cases, so where not a heterozygous variant or even homozygous variant, that's the most easiest one to call, is present, but where during the development of the fetus or during the development later, there has been a certain degree of genetic alteration, and not all the cells are identical, but there's a subset where a genetic variant has been introduced, and this genetic variant then can be causative for the disease. And these somatic variants are impossible to be caught by a 30x genome, which is the standard kind of sequencing depth you look into when you do a whole genome sequencing for genetic diagnostics. Of course, if you do a 100x genome, you have everything what we have here, but nobody is currently approaching this kind of setup because it's simply too expensive. So with this highly uniform coverage, we cover the vast majority of this exome with over 100x, and we can detect low-frequent mosaicisms as well. And this is why we say, from an enrichment perspective at least, to start off with that, our EXOMEXTRA here is better than an exome and smarter than a genome. So now we have laid the best possible clinical basis for our genetic diagnostics. So what about bioinformatics? What can we do here? And similarly, like before, we looked into these details and say, okay, what can we do better? So first of all, and this refers to trio exome diagnostics mainly, what we take is we take these, so what we internally call the iBurp genes to that. So what that means is that we got feedback from the clinics that sometimes, for example, the father is not severely affected as the kid is, but still not quite right. Same can obviously happen to the mother as well. And when you do a standard trio exome diagnostics, you have these kind of variants which are passed on and show a different phenotype in the kid than they do in the parent, and these would be normally filtered out of this whole process and be ignored. While we say, well, we know these genes, we know which ones might be having a reduced penetrance, which might have a very expressivity or an imprinting effect, and we can compensate for that. So we take them back into the list and say, well, don't lose them. We need them to do. We need them to be analyzed. Then we have most of the times when you do analysis, you start off with single nucleotide variants. And you can have compound heterozygous situation where you have one single nucleotide on the one allele and one single nucleotide on the other allele. And both disrupt the gene differently. They come together, the gene is disrupted and the patient's phenotype is explained. But it can also happen that you have a single nucleotide variant on the one side and a copy number variant, whole exon deletions, for example, on the other side. This one needs to be called as well. If you ignore these, you will solve a substantial amount of cases not because of that. And obviously we said, well, we need to find a way that this is be automatically ranked and put into this list, because manually, again, this is dramatically amount of work and would increase turnaround time. So we're compensating here, and we are offering CNV, SNV combinations as part of our routine diagnostics. And then, especially speaking about trio exome diagnostics, a trio is not always possible. Sometimes the mother is lacking, sometimes the father is lacking, or sometimes the inheritance pattern of that disease maybe suggests a different kind of approach. And our dedicated bioinformatic pipeline is optimized to treat all different kind of family constellations in cases there is a lack of a certain person we would love to get. So, for example, we could take the aunt instead of the mother. That would get a little bit of information, obviously not to the same extent as the mother would be. And again, optimizing this, we are at the way to have just the smarter, better exome. And lastly, the treating physician needs to get a report that you can use in your treatment of the patient. So you need results that you can work with. And when we looked on that, we said, first of all, what do we need to do? So we're high quality, we believe in high quality. I mentioned that a couple of times before. And so our process is utilizing bioinformatics, of course, but it's still humans who do the reporting, because we believe in the combination of human intelligence with bioinformatic knowledge. And in order to ensure that each report comes to the level where we feel comfortable with, a total of 4 experts contribute to this report. The first one is the lead scientist who does the manual interpretation of the variants identified. The second one cross-references everything that has been done and double-checks all the results. Then we have a medical validation team that ensures the clinical usability of that results. And then last but not least, we have a clinical geneticist, a medical doctor specialized in human genetics, which is, by the way, in Germany, a profession that takes another 5 years after completing your medical doctor, to ensure that the report is to the highest possible quality, gives you the best insight. The second, I already mentioned, reviewed by medical doctors, so it ensures the clinical usability. We are obviously, and I showed you the one case before where we identified the TCN2 variant, but this just shows that we are looking into the most recent literature. So we have been pointing out not only the variant and say this is likely something, but also there has been a recent publication utilizing this as a basis for potential treatment. We are looking into the most recent literature to give the best possible results, to not only rely on databases which might be outdated, which have update intervals which are too long. So we need to be up to the most recent information in order to offer a result that we feel comfortable with. And then we find that a substantial amount of cases has reported variants of unknown significance, ACMG class V variants. And we're looking into this as a risk re-elevation program. So we keep track on these cases. We see if the classification has been changed. If it has been changed, we will report to you that there's a change which affects your patient and offer a free report on this update. So again, having something that is just a smarter, better exome. So to sum that up, we have an extra smart clinical design which has not only the coding region, it has a mitochondrial genome, it has deep intronic variants, and it's very uniform in coverage. We have in bioinformatics that has a proprietary algorithm design to ensure maximum sensitivity on calling variants with potential clinical relevance. And we have a medical interpretation team that ensures to give you the highest possible clinical usable results for your patients. And with this, we come to the conclusion that, in our opinion, we have achieved the goal to create the best possible diagnostic exome lineup that is there. Again, just very briefly, and I don't want to take over Martin's part, no worries, just give you a little bit like how this may look like in clinical practice. So we have a sample case here. We have a suspected Beckman-Wiedemann syndrome. We have overgrowth, macrocephaly, and you can read all of that on the slide. There is no blood analysis done and no further family member was affected on this. So when we looked into this into detail, and this on the left-hand side, you actually see how that at least partially looks in our laboratory. We have the index patient on the top level, and then right below we have the mother, and then we have the father, and then they have the reference. And what you see is that there's a variant that has been both in the index and in the asymptomatic mother. And what we saw here is that this is a parental imprinting gene. So the maternal allele is expressed. So the mother is asymptomatic, likely because she has inherited the variant from her father. The kid is affected because it has inherited the allele from her mother. And that's what I just said. So this is a variant in classical trio exome diagnostic that would have been sorted out. And this is just showcasing for us, this is exactly why we put all of these efforts into these bioinformatic algorithms, because a variant that has been sorted out in bioinformatics cannot make it into the diagnostic and therefore cannot make it into the cannot make it into the report. For the WUS re-elevation, also here we do see clinical impact. So we have a boy 11 months in age with an epilepsy, and we reported in November 2019, so that's a little bit an older case, an SCN8A variant, which was at that time classified as a variant of unknown significance. But due to an HGMD update in January 21, and we had based on a publication of 2020, this update triggered the WUS re-elevation program for that kid, and the variant can now be classified as likely pathogenic, and we could issue a new report for the patient. So, this gives you a little bit like the impression about our workflow. This gives you a little bit an impression about the lineup we're having in order to, as the basis for diagnostics and our working principles, but how do we do that into the clinical services we offer? So for Exome Diagnostics, we have mainly 4 offers at the moment. The one we call EXOMEFocus. It's a very comprehensive but cost-efficient service where we have a relatively short turnaround time of 2 to 3 weeks. And in urgent cases, depending on the clinical phenotype, that actually holds true for every case we have, urgent cases based on the clinical phenotype are accelerated. In that particular case, it can be as low as 10 working days. It's a singleton analysis and it focuses on very clear results. We have a single exome, and I will come to all of these in a separate slide to give you an idea what it's utilized for, what's our vision to use it. We have a single EXOMEXTRA. And this single EXOMEXTRA just offers the most insights possible on a singleton exome. It's a different kind of approach where we do. And also I will get to that a little bit in a moment. The trio exome. The trio exome is actually the most powerful tool we have in NGS-based genetic diagnostics. We utilize, I mentioned that before, the 2 parents and the kit. And based on this exome-wide segregation analysis, we can just increase clinical usability, increase solving rates dramatically. And then this is something that has been started off very slowly, but has really hit a spot, I have to say, is the prenatal exome. So this is something where we actually also had been on the ASHG last year, 2021, giving a presentation upon, is when we have ultrasound findings in a fetus, identifying the genetic cause of disease and helping thereby with an estimate of disease progression into this fetus, and maybe also catching side effects where we have our side results, where we could identify metabolics that enable early treatment directly after birth. So we'll come to all of these now in a second. But this also something, and that you can actually find on our homepage as well, gives you like a summary. That's a small part of it. It gives you like the interpretation, what are we doing, which variants we're doing. Obviously, when we have class 4-5 variants, so we don't report any WUS, it's very hard to do WUS re-evaluation program on that. And the iVerb variants, for example, can only be utilized in a trio exome setting because we need the information on the inheritance in order to utilize the information on the iVerb, while in others, this might anyway be included. I mentioned before, trio exome diagnostics gives the highest solution rates, gives the highest clinical insights, but we understand that this is not always possible. And also, we understand that there is a price difference between a singleton analysis and a trio analysis. So really depending on the diagnostic question and on the samples available, we offer a diverse setting of diagnostic strategies to suit best the individual patient. So for the EXOMEFocus, the idea of the EXOMEFocus is to offer a singleton exome diagnostics, which is fast and cost-effective and offers clear results. This is why we are focusing on the ACMG classes 4 and 5 in this report, because you sometimes have settings where you don't really want to have variants of unknown significance. So envision you do this as a newborn screening approach and you want to see if the kid has some metabolic diseases that you might be able to treat upon. You do not want to cope with a variant of unknown significance in a gene of unknown significance. What are you going to do with that kind of results? So very clear results, very stringent, and saying, okay, we have identified something that is actionable in that kid, so that is something to do, to act upon, while you leave out everything that might only scare off the parents. And there's another option to utilize this as a very fast and cost-effective approach. What we see is that this is a good starting point when you want to get the, let's call it easy cases, so the cases where they have a very clear result fast, and the singleton would offer this. Before, in the negative cases, you expand to trio exome diagnostics and simply save time by starting with this approach and only subsequently offer trio exome for the ones. Of course, The EXOMEFocus, and we just launched that very recently, incorporates the knowledge and experience we have gained over the last 12 years. It's based on our proprietary EXOMEXTRA enrichment in order to maximize the laboratory usability, maximize the laboratory output and the fundamental basis for the diagnostics. But on the diagnostic approach, we have a very targeted setup here. The single EXOMEXTRA, on the other hand, is a little bit a different approach. So first of all, it offers the most comprehensive, most broad exome diagnostics we can envision. It is the diagnostic of choice for the cases where trio exome diagnostics is not possible. So we would always recommend utilizing comparative familiar exome diagnostics, mostly the trio, because it just gives the highest solution rates, the best results, but it's not always possible. And if this is the only way to go, you can utilize the exome single and still get extremely very good results. So again, it offers the most broad analysis to what's possible on an exome singleton. It is based on a phenotypically driven customized gene panel. So what we do is we take the HBO terms, we take the clinical information that has been provided on this specific case, and we create a gene list. And this gene list is then detailedly analyzed. All the variants in that gene list are analyzed until we solve the case completely, or it cannot be solved at all. We report here on not only the variants of the pathogenic and likely pathogenic variants, but we also report variants of unknown significance in that patient. This is, in this case, very important because here, in this kind of setup, you want to follow up with this variants of unknown significance, or maybe do in-segregation analysis in different family members to expand the analysis on this. Okay, for the trio exome diagnostics, as I mentioned, it offers the highest clinical insights, and it is the most powerful tool we offer in genetic diagnostics. The trio exome offers the sequencing of both parents, genetically parents, and the index, and then we do an exome-wide segregation analysis. And due to this information we gain, due to this exome-wide segregation analysis, approximately 30% of the variants of unknown significance that we would describe are actually set into an ACMG class 4-5, likely pathogenic, most of the time likely pathogenic variant, because we simply can identify, due to the segregation, we get more scoring for that and we can solve the case. That's really a big benefit on the trio exome diagnostics. And due to our enrichment, due to our bioinformatics utilizing iVerb and so on, we exceed standard trio exome diagnostics by far. The prenatal exome is a little bit more delicate. It offers very many clinical insights. And what we're looking here, so the setup we have is that we have a pregnancy with ultrasound findings. And these ultrasound findings we want to have the genetic cause for, because due to the limited phenotypic information we have, or the physician has, on the fetus, it's very difficult to make a proper diagnosis, a proper disease prognosis. It is very difficult to make a proper disease prognosis, and this is very important for the pregnant mother, for the father-to-be, in order to see what can be done, how we can act upon that. And this is just, when you have these kind of ultrasound findings, extremely important for the parents to know. And besides the identification of the causative variant of the anomalies seen in the ultrasound, the prenatal analysis is always used, or at least when we have these samples already in-house, we feel obligated to screen outside of the original order for everything that we can identify that allows us, or allows the treating physician, to interfere with the disease progression immediately after birth. This can be something like a metabolic disease, where with a special diet you immediately apply to that newborn and therefore milden or even get the phenotypic progression of that kid away. So this is just something, especially in newborns, the earlier you can act, the better the outcome is. We have seen that now in a couple of cases, that it's just very important to intervene as early as possible. So this is the setup we are looking into for clinical genetics in Trio Exome or in Exome Diagnostics. But one point I want to also make is that in our opinion, it's extremely important to work together. So in order to offer the most for the patients we're sharing here is we believe in the collaboration. We believe that we have to share information on the patient. We believe that we have to work together in order to get the best for that patient. We need clinical information. We need the insights. Our team might come back and ask additional questions, like could it be that the patient also displays a certain phenotype? And this has, in quite a number of cases, actually then solved that case, because there are differential diagnoses that maybe not that often, but still are present. So we need to work together. And the other part where it's clear that we strongly believe in collaboration is that we share our variants we have identified. We have this huge database. We sit on it, but we utilize it, not only for ourselves, but we share it with the community. We strongly believe that we, as whole humanity, have to work together in order to solve more cases. And this is actually why we are the largest non-US contributor to ClinVar. At least I was forwarded that particular slide by a friend of mine on the ACMG meeting in this year, 2022, that we are actually indeed the one laboratory outside US that contributes most to ClinVar. And we are quite proud on that. So with this, actually, I want to thank you all for your interest in this part of the talk. And I'm very happy to hand over now to Martin, who's already waiting here, to give you the second part, where he explains a little bit more on the clinical cases we are looking into and gives you more on that. And subsequently, we're very, very happy to take your questions. Thank you.
Thank you, Stefan, for the introduction. I'm Martin Ritthaler from the Medical Validation and Diagnostic Support team. And today I'm going to show you our exome in action and the clinical applications. And as Stefan showed you this prime example before, our case with Layla was really a good example how diagnostics could benefit this patient. And for that, we really could help Layla to lead a normal life. But now I'm going to show you our EXOMEXTRA, and I want to talk about the one-size-fits-all solution which we have, that our EXOMEXTRA is more or less the Swiss Army knife. And I'm going to start with the trio exome sequencing. And for trio exome sequencing, it's important that each healthy individual has several thousand benign variants. And for that, bioinformatic filtering, so comparing the sequences of the parents with that of the index, helps to identify de novo variants, and so variants that are only occurred in the index patients. However, we can also identify biallelic variants, not only homozygous variants, but also compound high heterozygosity. So trio exome sequencing also allows for phasing. Further, we can identify X-linked variants as well as copy number variations like losses and gains. And from literature, we know that there's a solution rate of 37% for trio exome analysis and compared to 21% for single exome analysis. And here we have our first case of a trio exome in routine. And there's a boy aged 2.5 years. He showed prenatal growth retardation, global developmental delay, especially for language and motor development. He also had a mental retardation, muscular hypertonia, and neonatal focus seizures. A microarray was performed beforehand and turned out to be negative. He's a child to healthy parents that were not consanguineous. What we then performed was a trio exome. And as Stefan told you before, this is our in-house software. And here you can see that the variant is only present in the index, so neither the mother, the father, or a reference bear this variant. And where is this variant located? It's in the gene KCNQ2. And it's a small deletion causing a frame shift in this gene, leading to nonsense-mediated RNA decay. And if we look into the literature, we see that the KCNQ2 gene is associated with epileptic encephalopathy, which also fits the phenotype of this patient quite well. However, not all variants are found in the coding regions. And again, the human genome has roughly 3 billion bases, and only 1.5% of the genome are protein coding, so that's the exome. And 89% of all pathogenic variants are located in the exome. However, there are also so between genes and intragenic non-coding variants, for example, in the promoter region, the enhancer, or the intronic regions. And from HGMD, the Human Gene Mutation Database, we know that there are 17,000 non-protein coding pathogenic variants. So, and here we have the case of 2 affected children, 2 healthy parents from Kosovo. Both showed more or less the same phenotype. Both had white matter disease, hypotonia, seizure, blindness, deafness, respiratory insufficiency, and pubertas praecox. And what we did in 2016 was a quattro exome analysis with the Agilent V6 enrichment. However, we got a negative testing results. So we went back in 2020 and analyzed this case again. There we performed a trio exome with the index, the girl, and we did this with our own enrichment. And here we found a variant in the gene UFM1, a small deletion of 3 nucleotides. And what's interesting about this variant is that it's before the start of transcription. And also this variant had a nice coverage, so that was really decent with 223 sequences or reads for this region. And we then went back and asked us, why did we miss this variant in the quattro exome? And there we looked again into our data and found that the variant was missed due to low coverage. So we only had 9 sequences for this region, and that was not sufficient to detect this variant. And if we look into the literature, we find that UFM1 is causative for HLD14, so hypomyelinating leukodystrophy, which also fits the phenotype of the 2 affected children. And further, the variant that we found is a founder mutation in the Roma population, which also fits the background of the parents. And the next case is are 2 patients, 2 boys, aged 9 and 13 years. They both showed immunodeficiency, so hypergammaglobulinemia, reduced B cells, psoriasis, bronchiolitis, repeated infections, skeletal dysplasia, dental abnormalities, hypothyroidism, and small optic nerves. What we did here was a dual exome analysis where we looked for shared variants of the 2 affected boys. And what we found were 2 variants in the gene RNU4-ATAC, which also had decent coverage of 160 to 220 sequencing reads. And we then went back and looked at an older enrichment, and there we would have missed these sequences or these variants as well due to low coverage. So these regions were not sufficiently covered in all the enrichments. And if we look further, if we compare single reads, we find that each variant is located on a different read. So this allows for phasing. So we can attribute this variance to different alleles and hence to different chromosomes. And therefore, compound heterozygosity was confirmed. And as we know, RNU4-ATAC is associated with the Roifman syndrome. And what else is interesting about this gene is that's a small RNA coding gene. So it doesn't code for a protein, but is part of the, or is a component of the spliceosome affecting more than 90 target genes. And hence, it has this pleiotropic presentation affecting the skeleton, the immune system, and the teeth. and as I said before, is associated with the Roifman syndrome, which fits the phenotype of those patients. And therefore, this case could be solved. Next, I'm going to show you what we can do for CNVs, that we have an array-like coverage there. And here we have a case of a girl aged 1.5 years. She showed global developmental delay, especially for speech and motor development. She was microcephalic below the 3rd percentile and showed no dysmorphic signs. She was the child of healthy parents. What we did here was a trio exome sequencing as well. And what you see here is again our in-house software and our CNV plot. And for CNV detection, we compare the number of reads of the index with a reference. And if we have less reads there, we have a deletion or a loss. And if we have more reads, we have a duplication or a gain for this region. And what we found here was a microdeletion in chromosome 17, especially in the region 17p13.1. And it has the size of 288 kilobases. So that would be a size you would normally expect from a microarray analysis. And if we look into the literature, deletions in these regions are also associated with the microdeletion syndrome, which also fits the phenotype of this patient. Here we have another case, a girl aged 11 months. She was a collodion baby, had generalized erythroderma, intracorneal cleft, and orthokeratosis. Here we also performed a trio analysis, and what we found was a variant in the gene SERS3, which was paternally inherited and heterozygous. And since the gene is associated with autosomal recessive ichthyosis, this variant alone was not sufficient to cause her phenotype. Therefore, we looked a little bit deeper. What we found was a deletion in exon 2 of the SERS3 gene, so a single exon deletion. And this deletion was inherited from her mother. So the patient was compound heterozygous for SNV, a single nucleotide variant from her father, and a copy number variant from her mother. Therefore, the diagnosis of ichthyosis could be made. And when you look at pictures of the literature, here on the upper left, you see a collodion baby. And this phenotype is associated with the SERS3 gene. So this case could also be solved. Next, I'm going to show you what else we can detect with our EXOMEXTRA. And here we have more applications. A girl aged 10 months, she showed a neuromuscular disease and had a syndromic metabolic presentation. She showed hypertonia, respiratory insufficiency, mental motor developmental delay, a hyperlate, mild facial weakness, and bilateral strabismus. Karyotyping, microarray, and SMN1 MLPA were negative beforehand. She was the child of healthy parents that were non-consanguineous. Therefore, we did a trio exome analysis. And what we found here you can see our ROH plot, or plot for regions of homozygosity. And what you can appreciate here is that variants that are heterozygous scatter more or less around the baseline here, whereas you usually have only few variants that are homozygous that are in the upper part of this graph. However, for chromosome 15, we have a stretch of homozygosity, so the entire chromosome 15 was homozygous. This was indicative of isodisomy 15. We then went further into our data and compared it with the parental data, and this showed that all the homozygous variants came from her father. Therefore, we had a paternal isodisomy of chromosome 15, and this was also confirmed by methylation-sensitive MLPA. Therefore, the diagnosis of Angelman syndrome could be made. Next, we have mitochondrial variants, and what we can do here, I'm going to show you. And here we have a girl, aged 2 years. She showed severe developmental delay, hypotonia, epileptic encephalopathy, and central blindness. She is the child of 2 healthy parents, and what we did here was 3 exome analysis. And what we found was a variant in the gene MTND2, so that's a mitochondrial gene. And what we found was had a really low heteroplasmic level of only 8%. So only 12 of 155 sequences bared this variant. And from literature, we know that this gene is associated with isolated complex 1 deficiency, which would fit the phenotype of this girl. However, the variant is still classified as a variant of unknown significance. And therefore, maybe in the future, this variant can be reclassified. Maybe it will get described in the literature, or we find more patients with this variant. And with that, I would like to conclude. I showed you that EXOMEXTRA is a powerful tool, especially for genetic diagnosis of syndromic disorders. It can be applied to a wide range of clinical issues and detects genomic losses and gains in an array-like manner, and it can also even detect single exon deletions and duplications. It allows for the detection of known non-coding variants due to our proprietary enrichment and has a good coverage for mosaic detection. Further, it may hint to imprinting disorders. And with that, I would like to thank you, and we are now glad to take your questions. Thank you.
CeGaT, the best possible exome diagnostic.